Cello students, welcome back. We've all been there, haven't we? That awful feeling when your stomach just lurches and your gut decides, nope, not today. It's one of the most common complaints. So today, we're going to go beyond just the discomfort. We're going to dive deep into the science of nausea and vomiting. We'll find out why it happens, and more importantly, how we, as future doctors, can master the drugs to bring it all under control. So, when you feel that wave of nausea, it's not just some random event. It is a very, very carefully orchestrated signal from your body's internal command center. It's an alarm bell, basically. So in this explainer, we're going to decode that alarm. We are going to trace the complete wiring from your gut all the way to your brain so we can understand exactly what is going on. Let's get started. First up, let's talk about a truly amazing fact about our bodies. Did you know your gut has its own brain? Yes, seriously. It's called the enteric nervous system, or the ENS. And this isn't just a few nerve cells here and there. It's a whole complex web of neurons right there in the walls of your gut, making decisions completely on its own. That's why we call it our second brain, and it is the command center for all the signals we're discussing today. Okay, so how does the second brain communicate? Well, the main language it speaks is through a chemical messenger you've probably heard of, serotonin. We just abbreviate it as 5-HT. Now, for our purposes, I want you to think of serotonin as the postman of the gut. It's running around delivering all these crucial messages that control everything, whether things move along smoothly or if an alarm needs to be sounded. All right, everyone, focus on this diagram now. This is our master blueprint for the entire topic. If you understand this, you'll understand everything. It all starts with this pink cell right here, the enterochromaffin cell, or EC cell. Now, when this cell gets irritated by something, say a chemotherapy drug or a bacteria, it releases our postman, serotonin. That serotonin then travels and delivers its message to these nerve fibers. This simple flow is the key to how all these drugs work. Now, looking at that blueprint, you can see that serotonin sends its messages down two main communication lines. The first is the intrinsic pathway. This is for local business. It just tells the gut muscles, hey, let's keep things moving along, what we call peristalsis. But if the signal is about a real danger, it activates the second line, the extrinsic pathway. You can think of this as the emergency hotline straight to the central nervous system, the CNS. This is the pathway that triggers the brain to initiate nausea and vomiting. Okay, let's move on to our first class of drugs. What happens if the gut is just sluggish? What if the traffic inside is not moving? Well, that's when we call in the prokinetics. Think of them exactly like the traffic police for your gut. Their whole job is to get things moving again. So what does a prokinetic actually do? Well, its main job is to enhance gastrointestinal motility. But, and this is a crucial point, it's not about just causing random contractions. It coordinates the muscular waves to propel everything forward in the correct direction. It's about getting traffic flowing smoothly again. Now, pay close attention to this slide. This is a very important clinical comparison between two extremely common prokinetics, metoclopramide and domperidone. Look at this one key difference here. Metoclopramide crosses the blood-brain barrier. Domperidone, on the other hand, does not, or does so very, very poorly. This single fact explains the major difference in side effects. Because metoclopramide gets into the brain, it can cause those scary extrapyramidal symptoms, muscle dystonias, those abnormal muscle movements, especially in children. Domperidone, by staying out of the brain, almost never causes this problem. This is a critical point to remember for your practice. Okay, so prokinetics get things moving. That's clear. But what if the problem isn't a sluggish traffic jam? What if the problem is that emergency signal being sent to the brain over and over again? Well, to stop vomiting, we need a completely different strategy. We need to block the signal, and for that, we use antiemetics. Now, it's always important to remember that vomiting is actually a protective reflex. It's our body's way of getting rid of something harmful. But sometimes, like with chemotherapy or after a major surgery, that alarm system it goes into overdrive. It's either a false alarm or it's just way too strong. That's where we as doctors need to step in and cut the signal. And this slide shows us exactly where these antiemetic drugs work. Let's go back to our master blueprint for a second. See the extrinsic pathway. That's the line going up to CNS. That is our alarm signal. So the job of an antiemetic is to act like a pair of scissors and just snip this wire. It intercepts the message before it can ever reach the brain and cause that feeling of nausea. Now, when it comes to blocking that signal, we have a very special, very precise class of drugs. They are the 5-H3 antagonists. But, we all know them by their nickname, the cetrons. Why? Because all their names end with cetron. Let's take a closer look at how they work.
So let's look at the main one, ondansetron. This is a really smart drug. It doesn't just block things randomly, it specifically blocks the 5-HT3 receptor, the exact letterbox for that alarm message on the vagal nerve. Its primary use is in two major scenarios you'll see all the time: chemotherapy-induced nausea and vomiting, or CINV, and post-operative nausea and vomiting, PONV. And here is the absolute game-changing part. Because it only targets serotonin receptors and not dopamine, it does not cause those scary muscle dystonias. This was a huge clinical breakthrough.
But listen, not all cetrons are the same. Look at this comparison. Ondansetron has a fairly short half-life, just a few hours, which makes it perfect for acute, immediate nausea right after surgery or chemo. But what about the nausea that shows up a day or two later? That's very common with chemotherapy. For that, we have palonocetron. Just look at that half-life, around 40 hours. It sticks around in the body for much, much longer, making it way better for that delayed nausea. So you see, it's about picking different tools for different timing.
So, we've covered the main tools in our toolkit, the prokinetics and the antiemetics. Now for the most important part. Let's put it all together. How does a doctor actually decide which tool to use and when? I promise you, it's not a guess. There is a clear, logical process behind it. Here is the clinical thought process broken down into 4 simple steps. First, you have to identify the core problem. Is it a motility issue that needs a prokinetic, or is it a signaling issue that needs an antiemetic? Simple. Second, you find the cause. What is triggering this? Is it a drug? Is it postoperative? Is it a migraine? Third, you decide which pathway to target. Are we going after the dopamine system or the serotonin system? And finally, and this step is absolutely non-negotiable, you must check for side effects and contraindications. This systematic approach is how you turn knowledge into effective, safe treatment.
And this brings us to the most important point of the entire lecture. Really listen to this. Memorizing drug names is easy. Anyone can do that. The real key to being a great clinician is understanding the underlying wiring that you are trying to fix. When you understand that circuit diagram we've been looking at, you're no longer just prescribing a pill. You are intervening with precision. Always remember, the mechanism dictates the application.
So we will end with this thought. The gut, our second brain. It is incredibly complex. It's constantly sending messages, talking to us, but by understanding its chemical language, the language of serotonin, and by understanding its neural pathways, we are getting better and better at listening to, interpreting, and even mastering those messages. And that ultimately is what modern medicine is all about.